Hello everyone, I am Dr. Madhavan, second year junior resident, the Department of Radio Diagnosis, AIMS Bibinagar, Hyderabad. Today I am going to present a learning case. So it is a 29-year-old male came with complaints of swelling in the dorsum of the right foot since 6 months. History of previous surgeries done at the same site 3 times prior. So HPE report on that time, previously one HPE report sent, so that revealed spindle cell neoplasm in favor of fibroma of tendon sheath. So patient was referred for radiograph, MRI and ultrasound guided true cut biopsy to our department. So it is a dorsiplantar lateral and oblique radiograph of the right foot, and it is showing soft tissue density lesion involving the dorsiplantar region with intermetatarsal space widening at first metatarsal and second metatarsal spaces. Intermetatarsal widening. The soft tissue doesn't show any calcification within. However, it is scalloping the third metatarsal head and showing the benign type of periosteal reaction along the medial border of the medial aspect of the body of the second metatarsal, and we can see here also on the base of the first metatarsal benign solid periosteal reaction is happening. So per se there is no erosion. However, here we can see some permeative type of lesion. So depending upon these X-ray finding, it may be a soft tissue lesion with involvement of the adjacent bone, and we can see scalloping. Scalloping indicates chronic nature of the swelling of in the patient. So the patient underwent MRI. So it is a selected coronal T2 weighted and PDFS images. So in the T2 weighted sequence, we can see the heterogeneous lesion, heterogeneously hyperintense lesion involving the dorsoplantar aspect, and this is causing widening of the first and second web space, intermetatarsal spaces. PDFS also the lesion is hyperintense, and these are selected sagittal images of the disc T1. It is PDFS. In the T1, the lesion is intermediate in signal intensity. In PDFS, it is hyperintense, but we can see multiple flow voids, multiple blood vessel, dilated blood vessels here on the plantar aspect of the foot, sole of the foot. And on DWI, the lesion shows deficient restriction with counted mean ADC of 0.7 into 10 to the power of -3 millimeter square per second. And this is a PDFS, and it is showing involvement of the bone also. So we can see second metatarsal infiltration along the inferomedial border. There is cortical erosion with involvement, a bone marrow involvement also, hyperintensity involving there. And on the third metatarsal, we can see thinning of the cortex. We can't able to see the cortex on the medial aspect of the body of the third metatarsal bone. And these are the pre-contrast and post-contrast images. The lesion shows heterogeneous contrast enhancement, and this is the GRE images. On GRE, there is no evidence of blooming, and we can see multiple T1, T2 and PDFS hypointense septations within, and it is causing displacement. It is causing the displacement of the flexor and extensor tendons. So considering these findings, we have given as well-defined lobulated lesion involving the plantar and tarsal aspect of the foot at the level of first to fourth intermetatarsal spaces, first to third with involvement of the second and third metatarsal heads bodies as described. So features suggestive of soft tissue sarcoma, the tumor with myxoid component we have given. So ultrasound guided core needle biopsy was done in this patient in our institute, and before that differential diagnosis. So it may be any soft tissue tumor with involvement of the adjacent bone. It is the entity. Since it is showing T2 hyperintense signal, we can say it is a myxoid component. Lesion with myxoid component also would not be ruled out. However, the differential will be malignant peripheral nerve sheath tumor. So previous history of neurofibroma, previous history of schwannoma in that area with involvement of the adjacent bone, neurovascular infiltration, everything will favor malignant peripheral nerve sheath tumor. But this patient doesn't have anything in this aspect. Then Ewing sarcoma. So in a bone involvement with extensive soft tissue involvement will be common in Ewing's. So considering the age group of the patient, Ewing sarcoma also we can keep in mind. So ultrasound guided core needle biopsy done. There they showed the tumor cells arranged in dense cellular sheets to vague fascicles in a variably collagenous stroma. They show oval to spindle nuclei with evenly distributed chromatin, inconspicuous nucleoli and indistinct cytoplasm. Mitotic figures are not apparent. They show diffuse intense immunoreactivity to BCL2 and CD99. They are focally immunoreactive to S100. Pancytokeratin shows focal faint immunoreactivity. They are negative for smooth muscle actinin, desmin, CD34, K67 index, so 10%, that is low proliferative index. So feature suggestive of synovial sarcoma. So coming to brief discussion about synovial sarcoma, it's the fourth most common type of soft tissue sarcoma, 2.5% to 10.5% incidence, all primary soft tissue malignancies worldwide. It most often affect the extremities. Age group is 15, so younger age group will be involved more. It is multilobulated, heterogeneous, infiltrative, and due to hyperintense masses with marked contrast enhancement. The classic sign will be triple sign. So T2. So in the T2 images, we can see heterogeneous nature of the tumor. Iso, hyper, hypo, all intensities we can able to see. And bowl of grape sign. Bowl of grape will be whenever the tumor shows hemorrhage, we can see blood fluid level within the lesion. And cell of origin, even though the lesion is named as the tumor is named as synovial sarcoma, it does not originate from the synovial sheath only. This is mesenchymal cells that is differentiated into synovial cells. That this is the cells of origin. The modality of choice is MRI for the local extent and adjacent involvement, neurovascular bundle and nerve involvement, muscular involvement. Aggressive features will be bone involvement, neurovascular encasement, muscle invasion. So distant metastasis to the lungs and lymph node. The treatment is surgical resection with or without radiotherapy in case of non-metastatic tumor. And for the metastasis, we have to give chemotherapy. It is efosfamide with or without doxorubicin. So post treatment also we can follow up the patient with either CT or MRI. PET CT also can be done for metastasis purposes. So the prognostic factor, younger age, it is a favorable prognostic factor. Smaller the tumor size, better will be the outcome. The extremities have better prognosis. Perioperative radiotherapy has better prognosis. The poor outcome is osseous and neurovascular invasion. So these are my references. So thank you. Stay tuned for more videos. Thank you.